Hello, everyone. Thank you for taking the time to join us on this webinar today. Our topic is Rural Health Clinic Reimbursement Updates, and my name is Cassidy Avila. I am the Program Coordinator for the newly launched Rural Engagement Program at Texas A&M Health. I have a couple of housekeeping notes before we begin. We are recording the webinar and we'll make a copy of it available along with the slides as soon as possible in a follow-up email from the Rural Engagement Program. There will be time today for Q&A at the end of the presentation. So if you would like to drop questions into the chat box during the presentation while they're fresh on your mind, please feel free to do so, and I will make sure our speaker sees those during Q&A. You can find the chat box on the bottom toolbar of your Zoom window. Simply click the drop-down arrow and select everyone or my name, and either will work for getting your question to us. It is now my pleasure to introduce our speaker, Marty Ross. Marty is a principal with PYA, a national healthcare consultancy, and serves as the director of the firm's Center for Rural Health Advancement. Following a successful 2-decade career as a healthcare regulatory and transactional attorney, Marty now serves as a trusted advisor for providers navigating the ever-expanding maze of healthcare regulations. Marty, welcome, and thank you for being here today. It's all yours.
Great. Thanks, Cassidy. It's a pleasure to be here. Greetings from Kansas City. I have to say it, you know it, the home of the now twice repeat Kansas City Chiefs. So things have been a little crazy around here, but let's settle down and talk about rural health clinics for the next hour or so. So let's start with the basics. Why would anyone want to be a rural health clinic? Why would you put yourself through the work of having to comply with the conditions of certification? Why would you work in this very unique reimbursement model? And truly the motivation comes down to the opportunity to secure enhanced traditional Medicare and Medicaid reimbursement for RHC services. And that's a defined term. We're going to talk about at length today. Generally, and again, today we're going to focus on the traditional Medicare reimbursement rules. As a general rule, state Medicaid programs follow the traditional Medicare payment methodologies. There are variations. As we always say, there's not one Medicaid program. There are 56 Medicaid programs, each with their own unique rules and applications. And how Medicaid MCOs reimburse RHCs typically is also a matter of the state Medicaid program and their contracts with those Medicaid MCOs as well. So that even adds an additional layer of complexity. With regard to other payers, Medicare Advantage, commercial payers, those rates are a matter of negotiation between the RHC and the payer. Note that for Medicare Advantage, rural health clinics do not receive wraparound payments, as do federally qualified health centers. As a provision in the FQHC regulations, which allows additional payment to an FQHC if the rate it receives is below the traditional Medicare rate, that is unique to FQHCs, does not apply to rural health clinics. In fact, let's delve in a little deeper on the difference between RHCs and FQHCs. This creates confusion because CMS tends to develop regulations for both RHCs and FQHCs in alignment. In fact, the conditions of coverage are for RHCs and FQHCs, although there are provisions unique to each. But there are some very important differences in how these two programs operate, how these clinics function. For example, while FQHCs are eligible to participate in the 340B drug pricing program, RHCs are not eligible to do so. Federal Tort Claims Act protections that extend to FQHCs do not extend to RHCs, and nor do RHCs receive the dedicated grant funding that FQHCs that have been approved for participation in the Community Health Center program receive. So additional benefits to being an FQHC, which RHCs do not enjoy. However, there are additional requirements applicable to FQHCs that are not applicable to RHCs. The first being the governance provisions. FQHCs have to be governed by must have a governing body that's comprised of at least 51% of patients or patient representatives. And typically, FQHCs operate as a nonprofit organization or as a part of a public entity. RHCs, by contrast, can be for-profit or not-for-profit. The ownership of an RHC, with the exception, of course, of provider-based RHC, but ownership of an independent RHCs are not dictated by regulation. So that provides greater flexibility. Secondly, RHCs are not under an obligation to provide services with regardless of ability to pay. So FQHCs, because of the additional financing they receive, particularly through the grant funding program, through 340B drug pricing, for example, they have the added obligation of what we often call the all-comer rule, that they must provide services without consideration of ability to pay, must maintain a sliding fee schedule. Those rules do not apply to rural health clinics. So it's important to appreciate these distinctions. Oftentimes, working with RHCs, learn that they tend to believe these additional obligations that are applicable to FQHCs apply to them. But we make sure that they're very clear of their obligations as part of the RHC program. So how does one become an RHC, or how does one maintain their qualification as an RHC? At the time that you apply, the physical plant must be located in a rural area that has been designated as a shortage or underserved area by the Health Resources and Services Administration within the last 4 years. You'll find tools on HRSA's website to determine eligibility. This has become much more user-friendly than long ago when we went through quite a long, drawn-out process to make those determinations. Now you can determine your eligibility with a few clicks on your computer. The good news is that once you're determined to meet the requirement at the time of your application for certification, there is no decertification if the location of the facility loses its geographic eligibility or shortage designation. So I guess in short, once an RHC, always an RHC, without regard to whether you're located currently in an area that's been designated rural or one that's been designated as a shortage or underserved area. Secondly, the clinic that applies for RHC qualification must satisfy the RHC conditions of certification, which you can find in Title 42 of the Code of Federal Regulations, Part 491, and you demonstrate that compliance through a state agency survey. So you submit the application, the survey is scheduled, the survey occurs, the agency determines compliance, they forward that to the regional office, and then final determination is made by CMS for the RHC designation. That is one of the challenges of RHC conversion, is getting in line for that survey, especially coming out of COVID. A number of states had significant delays in completing those agency surveys. That's starting to get better as we understand now, but that has been a particular issue with folks joining the program. And we'll just in a minute discuss why we've seen an influx in clinics interested in joining the RHC program. Specifically, let's drill down on a few of those conditions of certification. The first regards staffing, that an RHC must employ at least one nurse practitioner or physician assistant. You must maintain that employment. There are allowances for exceptions for periods of time as a clinic is attempting to replace a nurse practitioner or a physician employment who has left employment. Also, you must have a nurse practitioner, a physician assistant, or a certified nurse midwife, working on site, available to see patients at least 50% of the time that the clinic is open. So again, you are required to post your hours of operation. At survey, there's the expectation that when you compare schedules, that there will be one of these non-physician practitioners present at the site, available to see patients 50% of the time. In addition to the staffing requirements, an RHC must perform specified lab tests on site. You'll hear to these referred to as CLIA waived tests. And having the capacity to do those tests is critical, even though the tests themselves as we'll talk about, are not RHC services. You must have the capability to provide first response services for common life-threatening injuries and acute illnesses. Very broad language that's in those conditions of certification. CMS has not really drilled down to establish any specific requirements, but an expectation of your ability to demonstrate not a level of care that an emergency room would provide, certainly, but you could respond to an emergency within the clinic. And finally, you must provide primary care services, 51% of total practitioner hours. Primary care services is not specifically defined by CMS. Generally, it's thought of the services being provided by within the specialties of family practice, internal medicine, OB, and peds. That does mean that RHCs can provide specialist services, either as having employed or contracted specialists who are routinely at the facility, or by conducting, outreach clinics at the facility as well. It's just the balance must maintain at that 51% of primary care services. Note also, I should have said this first actually, is that behavioral health services cannot be the primary purpose of the RHC. It can certainly be a complementary service, and it certainly can be part of that other 49% of the services offered. But for compliance with the conditions of certification, at least 51% of those total practitioner hours have to be for primary care services. And finally, keep in mind that each permanent location must be independently certified. Again, another distinction with FQHCs. FQHCs can expand their reach by expanding the number of sites at which they operate. And those multiple sites will operate under the one FQHC MPI, or CCN, excuse me, versus an RHC. It is each physical location must maintain independent certification. Now, that location can have mobile units. That location can have practitioners that go to patients' home or to skilled nursing facilities. But as that permanent location where services are furnished face-to-face with the patient, each must be independently certified. So with that background, let's delve into traditional Medicare reimbursement for RHCs. We're first going to focus on RHC services, but also discuss how RHCs can bill for non-RHC services. That creates confusion, because if it's a non-RHC service, how does an RHC get paid for it? It's just paid on the traditional physician fee schedule. And so we don't have the additional reimbursement considerations that apply to RHC services. And we're going to spend a good deal of time talking about RHC visits. This is, and we'll again break down the definition, that these are the face-to-face visits, or in some case, telehealth visits, between a practitioner and a patient that provides a qualifying service within that visit. Again, we'll delve down into that definition in a minute. But what distinguishes an RHC visit is the fact that it is paid at an all-inclusive rate, or the AIR. And the AIR amount varies depending on whether you are a provider-based RHC or an independent RHC. And now, since 2021, it varies based on whether you are a grandfathered or non-grandfathered provider-based RHC. So for those provider-based RHCs in hospitals with 50 beds or fewer that were certified prior to December of 2020, they receive an AIR that is calculated based on cost. And those AIRs can become very significant in the 200, 250 range based on the operating costs of that RHC. And that's done through a cost reporting process, and those rates are updated through that process. But only those grandfathered provider-based RHCs are going to receive cost-based reimbursement AIR. If you are one of those grandfathered clinics, the rules do permit you to relocate your permanent location. So move from one building to another. as long as that new building meets the rural requirement and the shortage or underserved area requirements. But a grandfathered RHC cannot expand its reach to additional permanent locations. So you are within the four walls, restricted to provide services that will meet that cost-based reimbursed air. But you can't expand your reach by saying, oh, this facility, this location is going to be part of our provider-based clinic, or that. You're just going to be still, you can move, you have to provide notifications of moving, but you can't split into more than two, or more than one, excuse me. All other RHCs, so including any non-grandfathered provider-based RHCs, as well as all independent RHCs, receive the standardized national air. That air remains the same. It does not vary by geography, as do payments under the Medicare physician fee schedule. It is the same for all RHCs, non-grandfathered and independent. Now, prior to April 1 of 2021, the air was low. It sat at $87.52 in 2021. And not surprisingly, because that air was low, we didn't see a lot of interest among physicians in converting to an independent RHC. It was buying a lot of obligations without seeing that offsetting advantage in reimbursement. So then we have the Consolidated Appropriations Act of 2021, and that rewrote the rules regarding independent RHCs. It's the CAA that discontinued cost-based reimbursement air for provider-based clinics other than the grandfathered clinics. And it's made the rule that all non-grandfathered RHCs, all independent RHCs are going to be paid on the standardized air. It also provided for that air to continue increasing over the next several years. So as we stand now in 2024, that air sits at $139. It will continue to go up through 2028. When we reach 2028, the air is going to be at $190. And then thereafter, it's going to be adjusted for inflation, similar to adjustments we see for inflation on the hospital outpatient or inpatient or outpatient prospective payment system, similar type of methodology there. Not surprisingly, this change in reimbursement for independent RHCs is really creating interest in the program. And we've done preliminary analyses for a number of clinics. And depending on their patient mix, as a general rule, it is always advantageous. Not as a general rule, I think everyone we've touched so far, it has indicated that there is a significant financial advantage to transitioning to an RHC. So that's why we're seeing more and more interest in this program today, because we've now made it a viable path for independent RHCs. So with that, let's delve into what is an RHC visit, which is, again, is reimbursed by air. It is a face-to-face, medically necessary medical or mental health visit, or a qualified preventive health visit between a patient and an RHC practitioner. You see there in that first sub-bullet the list of who qualifies as an RHC practitioner. The two that are in italics, licensed marriage and family therapist, licensed mental health counselor, are new in 2024. In fact, only beginning in January were these practitioners allowed to enroll in Medicare and receive their own NPI to bill directly for services. So we are kind of still feeling our way around how we incorporate these practitioners into an RHC. Of course, these practitioners have a defined state scope of practice. They must adhere to that state scope of practice in furnishing services within the RHC. But otherwise, these should be very familiar to you as a type of RHC practitioners. The services may be provided by the RHC practitioner to the patient in any location except the hospital inpatient or outpatient setting, and facilities with specific requirements that preclude RHC visits. So outpatient rehabilitation facilities or ambulatory surgery centers, for example, their requirements to participate in the Medicare program, by definition, define out the provision of RHC services at that location. But what it does mean is you can provide RHC services in the beneficiary's home. You can provide those services during a SNF Part A stay. More recently, since 2021, you can now furnish those services at the location at which a patient is receiving hospice services. And you can provide the services at the scene of an accident. What will vary, depending on location, is the revenue code that you submit with the claim. Again, we'll cover that in just a minute. Beginning in 2022, the rules changed with regard to behavioral health services because you can now provide behavioral health services in an RHC via telehealth, and that will qualify as a face-to-face encounter. And we'll go into greater detail on those rules shortly. But I didn't want you all to go, oh, hey, she says face-to-face services are necessary, but what about behavioral health? Note that, again, as part of the CAA, Congress redefined the benefit to include behavioral health services furnished via telehealth to be within the definition of the face-to-face service. The service that's provided in that visit is going to have to be a qualifying visit, that the type of service delivered is one that is considered appropriate to be furnished through an RHC and thus reimbursable under AIR. We have a document called the Qualifying Visit List, or the QVL, but which includes pages of CPT and HCPCS codes, but appreciate that it is a non-exclusive list. The fact a service does not appear on the QVL list does not preclude the provision of that service within an RHC. What you will find on that list are all the traditional evaluation and management codes, and then several procedures defined by specific codes. The list was last updated in 2016. You'll see at the bottom of the page the website where you can access that list. But again, think of it more as a guide, because yes, anything on the list is, shall we say, de facto going to qualify for an RHC visit, but the fact it is not on the list does not disqualify it. Included in RHC visits are the provision of preventative services. And you see here the list of those preventative services. This is a comprehensive list because by definition, an RHC visit includes preventative services, which are the initial preventative physical exam and the annual wellness visit, but then also preventative services that have been recognized by the U.S. Task Force on Preventative Services as a Class A or Class B service, based on the evidence that supports its value as a preventative service. What you see here on the list is those services that have received such a designation and thus can be provided and qualify as an RHC visit. Also appreciate, and again, when we get to billing, this will become more relevant, that these services are provided without a copay obligation for the beneficiary. What does not qualify as an RHC visit? So if this is the only service the beneficiary receives when they come to the RHC or when they have a face-to-face encounter with an RHC practitioner, it does not qualify for the AIR. That would include visits for medication refills, lab results, injections, some injections, we'll come back to that, and blood pressure monitoring. Suture removal, dressing change without any additional face-to-face visit. Anything that would qualify under CPT 99211 in a regular physician clinic, those nursing visits, is not going to qualify. Importantly, therapy services provided by a non-RHC practitioner also do not qualify as RHC visits, not reimbursed on the AIR. Instead, they would qualify as non-RHC visits, instead billed on the fee schedule. Reimbursement that the RHC receives for an RHC visit. Again, these are services paid based on the AIR, and Medicare is going to pay the RHC 80% of the applicable AIR, either the cost-based reimbursement or the current national standardized rate, for nearly all goods and services that are furnished in the course of an RHC visit. Okay, so it is an all-inclusive rate. Qualifying preventative services, however, are paid at 100% of the air if that's the only service provided that day. If you do an E&M visit and provide a preventative service, however, the all-inclusive rate comes in, and we'll talk about the impact of that. And of course, as we always say, less the 2% sequestration that's going to remain in effect long after I retire, and many of you as well. The beneficiary coinsurance, then, the obligation of the beneficiary is 20% of the RHC charges, not changes. I apologize for the typo, but charges, not 20% of the air. And you will find a number of publications that do not state that accurately. Some of the MACs state that inaccurately, but the calculation of the copay is based on your charges, not your air. Also, keep in mind that the Part B deductible, which is $240 in 2024, does apply to RHC services. So that deductible must be discharged before Medicare will pay the air rate to the RHC. Again, let's delve a little deeper into this all-inclusive. The rules require that encounters with one or with more than one practitioner or multiple encounters with the same practitioner on the same day at a single location are a single visit. That's one RHC visit. There are 3 exceptions to that rule. If a beneficiary suffers an illness or injury that occurs after the first visit that's going to require additional diagnosis or treatment on the same day, then that second visit would be a second billable RHC visit. Second is if a beneficiary has a medical visit and a behavioral health visit on the same day. Those are considered 2 separate RHC visits and are separately payable. And finally, if a beneficiary has an IPPE, that initial physical preventative exam, a visit, and then also receives a separate medical or behavioral health visit on the same day. And so that would also qualify as 2 separate RHC visits. Otherwise, any services or supplies that are furnished incident to the RHC practitioner services are included as a part of the RHC visit and thus are reimbursed under the all-inclusive rate. That includes services that are not furnished on the same date of service. They're actually furnished within a reasonable time frame before or after an RHC visit. Note that when you bill for those services that occur before or after, you still bill them with the date of service of the RHC visit. You do not provide a date range. That will blow the system up if you try to do that, in short. Also included in the all-inclusive rate is any professional component of diagnostic testing. So if the physician is interpreting an X-ray, for example, you do not separately bill for that. We will not be separately reimbursed, for that professional component of the diagnostic testing that rolls into the RHC visit. And then finally, minor surgical procedures that are performed at the RHC as part of that face-to-face visit are also going to be reimbursed under that all-inclusive rate. Note, however, that when surgical procedures are performed in RHC, they qualify as RHC services, and thus they are not subject to the Medicare global billing requirements that would apply to those services if furnished and billed under the Medicare physician fee schedule. So that allows for that additional reimbursement for follow-up visits that would not otherwise be available if the service is billed into the fee schedule in a regular physician clinic. So let's spend some time delving into claim submission, which of course is also going to impact reimbursement. RHCs bill for RHC visits on a UB04. You see there the electronic format. As you submit these claims, you list line item detail codes for all services that are furnished during the RHC visit. So what goes within that all-inclusive rate? Of the services you detail, you're going to append the CG modifier to that code that identifies the primary reason for the visit. That typically is going to be the E&M code or the procedure code. You can list the CG modifier on two lines if two separately payable services are furnished on the day. So again, if you have medical and a behavioral health visit, those would be two lines that have the CG modifier on them. If you have a first visit and then a subsequent visit based on a new injury or illness, that would be two separate line items with CG modifier on them. As you list on the claim, then your associated charges for each code are listed on the claim, except for that CG modifier line. That's where you're going to roll up all of the charges, except for preventive services and, of course, any other service line that has a CG modifier. That is critical because it's the CG modifier line, not the total cost line at the bottom, but the CG modifier line that is used to calculate coinsurance. So it's going to be 20% of that total amount is going to be the coinsurance obligation. This all became complicated at the point that RHC services, preventative care services furnished in an RHC, have no copay. And thus it becomes, necessitates this detail out of charges. That's a lot of information that's a lot more easily explained through an example. So here you have on the screen a table that shows a rather complicated RHC visit that occurred on January 3rd of this year. You see two CG modifiers, the first line and the last line. The first line is just an office visit, so an E&M code, 99213, and that's going to be the primary reason for the visit, so that's going to get the CG modifier. Then you see at the very bottom, RX management, which is a behavioral health code, again, separately payable, so you see the CG modifier there. But what we need to look at here is how do we get to the $220 charge on that first line item? For purposes of this example, I want you to assume that the RHC's charge for 99213 is $100. Okay, that's their base charge. So we've added another $120 to that line. How? Because it's the next several lines of services provided during that visit that are rolled into the all-inclusive rate. That's going to include, again, EKG, the professional component, venipuncture. So if you took blood for a lab, if you did a lab draw, you're going to charge that venipuncture code. If the patient needed an injection of Toradol, I'm going to have the injection administration code as well as the Toradol code itself. And let's go ahead and add a screening pelvic exam on this list as well. So all of that, again, provided the same date, is going to roll into that first CG line item. Pay attention to that second line, the OOEM add-on. This is the brand new outpatient office evaluation and management complexity add-on code that CMS began paying on the physician fee schedule this year. CMS did not directly address whether a RHC should include the add-on code when appropriate on its claims. What is clear is that the inclusion of that add-on code, that complexity add-on code, is not going to impact reimbursement from Medicare, but if it is included, it's going to impact the amount of the beneficiary's copayment. So as an RHC, at this point in time, given the guidance we have as CMS, it would be appropriate to include the add-on complexity add-on modifier if in fact that office visit that was performed met the longitudinal relationship criteria for the add-on code. And so you see here, we've included the add-on code as part of this service, even though it's not a distinct, it is a modifier on the E&M version, on the E&M visit. It is not a separate service. It's part of the, it is incumbent in the E&M. What you see here is the air rate being $139. We're going to calculate the total charge by adding together the $100 for the visit itself, and then each of the charges for the services listed here, with the exception of the screening pelvic exam. So you are not going to receive a copayment from the beneficiary on that screening pelvic exam, even though your reimbursement for that preventative service has been rolled into that CG modifier on the office visit. So while it was a win for RHCs to receive 100% reimbursement, 100% air reimbursement for preventative services, appreciate that's only going to work when the preventative service is the only service provided that day, when it's the CG modifier line. In that case, you'd receive the whole $139 for that particular service. In this case, because it's performed the same day, it's getting rolled into the air for the overall visit. We just went through the calculations here, what CMS would receive, what Medicare would pay on this set of services would be $222.40. That's based on 2 air times the 80%. And the RHC would charge a copayment of $64. That's based on the 220, again, excluding out the pelvic exam, plus the $100 for the RX management times 20%. As you noticed let's go back here real quick. As you noticed on our table, we've included revenue codes for the service. The revenue codes are primarily in the 052X category. 052X is indicating where the service is provided. Again, most of your service is going to be with 0521, which is the clinic visit to the RHC, but we also have provision for the other locations with the service may be provided. Note, however, that behavioral health treatments and services are billed with a separate revenue code, 0900. And again, if you're billing a medical visit and a behavioral health visit on the same day, and you want to include the CG modifier on each, it's only going to work if you have that appropriate revenue code, the 0900, listed on the claim. Okay, so there's RHC visits. Let's get into the other services performed by RHCs for which they receive unique reimbursement. And we'll start with telehealth. Now, again, prior to 2021, even during the early years of the pandemic, the first year of the pandemic, exactly, RHCs could provide telehealth visits and receive reimbursement with no distinction between behavioral health services and medical services. But with the Consolidated Appropriations Act of 2021, we changed the coverage. And we did so by creating telebehavioral health visits as an RHC visit. And so let's go through the requirements for you to get paid for a telebehavioral health visit under your air. That visit is going to need to have an audiovisual connection. However, it can be audio only if the patient cannot or does not want to connect visually. So it's patient choice, but otherwise you should have the capacity to do an audio visual visit. And then effective beginning next year, absent any sort of congressional action, you will have to have a face-to-face visit as a condition of billing telebehavioral health services. Specifically, you're going to have an in-person mental health service furnished within 6 months prior to initiating the telebehavioral health services. Unless, of course, the services are initiated prior to January 1st of 2025. And then going forward, you're going to have a non-telehealth visit furnished for that patient at least every 12 months. However, the practitioner can determine that requirement may be waived based on the patient needs, as long as that reason is documented in the medical record. So confusing set of rules. Right now, today, it's simply a matter of providing the service via telehealth and having the capacity to do audio visual, although it can be visual only at the patient's request. There is no requirement for any prior face-to-face visit in effect today. But again, the rules change on January 1st of 2025, absent Congress coming in and extending these exceptions to the face-to-face visit. Again, note that these services are billed with revenue code 900 with the appropriate CPT code, and again, the modifier CG. You're also going to add additional modifiers regarding the manner in which the service was provided. You'll use modifier 95 for both audio-visual connection. You'll use modifier FQ if it's audio only. That's indicating that, in fact, the patient elected audio only. And remember that your costs and encounters for telebehavioral health services are included on your cost report. So again, although it's telehealth and it's different and unique, it's being treated as an RHC visit reimbursed under AIR. Okay, that is in direct contrast to telehealth services furnished by an RHC for medical services. And here, coverage will continue through the end of this year under the Consolidated Appropriations Act 2023. If Congress does not act, then RHCs no longer will be able to be reimbursed for services furnished via telehealth. For now, through the end of this year, these services qualify for coverage so long as the service furnished via telehealth is one that is included on the CMS approved list of telehealth services. You see there on the screen the link to the complete list of approved telehealth services. Of note, for RHCs, note that telephone-only codes, the 99441, is included on that list. And a 99441 is a very limited service. It's at least 5 minutes of E&M services that are provided by a physician or an advanced physician practitioner to an established patient. So it's not for new patients, only for established patient. And also you cannot bill this code if it originated from a previously furnished, a service furnished within the prior 7 days, or if the patient schedules a visit within the next 24 hours or the soonest available appointment. So what this gets to is it's effectively a freestanding service. You're calling in, very limited communication between the practitioner and the patient. It's billed under 99441, but it is not billed under 99441, but it meets the requirements of 99411. If you meet those requirements, that allows you to bill under G2025. G2025 is the code submitted by RHCs for medical services furnished via telehealth. You do not use the CPT code or the HCPCS code for this service that was furnished via telehealth. So if I do it in person and it's an evaluation management services, I'm going to list on the claim 99213. But if I do that via telehealth, I do not list 99213 or whatever the appropriate code is. I instead just list 2025. I'm going to bill that with revenue code 0521. And in 2024, these services are reimbursed at $95.29, regardless of what the service is. So in some cases, you're going to receive less than the AIR for a service that had been face-to-face, you would have received the AIR. But in other cases, you're going to receive reimbursement that would not qualify for the AIR, such as telephone-only codes, and you're going to receive reimbursement that is significantly higher than what's available on the fee schedule. 99411, I think, reimburses maybe at $40. I'm not exactly sure on the fee schedule, but regardless of the service provided, if billed G2025, then it's going to be reimbursed at that 95. Well, it's going to be reimbursed at 80%, of 95.29. Also, note that the costs and encounters associated with medical telehealth services are carved out of the RHC cost report. Finally, the other opportunity for telehealth reimbursement is the originating site fee. This has been around forever and ever now. This is the code you bill when a patient is physically present at your facility, but they're receiving telehealth services from a distant site provider. So they come to your clinic, they turn on the telehealth machine, whatever it may be, and they're going to communicate with that distant site provider. You can then include on the claim Q3014 with revenue code 078X. And the reimbursement in 2024 for that code is just shy of $30. This is the same code that's billed by critical access hospitals when they serve as the originating site as well. Again, it's not going to roll in on it's going to be separately reimbursed, again, because it's not being billed as part of the RHC visit. Then it is up to the distance site provider. They will separately bill for the professional services they provide using place of service 2, patient not physically present in the home. And remember, that distance site provider is going to be reimbursed on the Medicare physician fee schedule. He or she is not providing an RHC service. It is only the RHC providing an RHC service in the form of that originating site fee. Next up, let's talk about care management services and some significant changes for 2024 regarding eligible services and the manner in which reimbursement is calculated. So an RHC that furnishes care management services is going to bill for those under G0511. They bill that code when they furnish the following services through a rural health clinical staff member under the general supervision of an RHC practitioner. So this work's being performed by staff. It's general supervision by the practitioner. And you see here the list of services. So the service you provide has to meet the Medicare billing rules to qualify as this service. As you know, for chronic care management, for example, CMS has developed a set of rules on the capabilities you have to provide, the capabilities you must have to provide chronic care management services, as well as the 20 minutes of clinical staff time performing that service. So you have to meet the requirements of the service, and then you bill for it under G0511. Now, prior in 2023, it was simply the first 4 services that qualified: chronic care management, principal care management, general behavioral health integration, and chronic pain management. Chronic pain management had been added in 2023. New this year, for 2024, are community health integration services and principal illness navigation services. CHI and PIN services, as they're referred to, are newly reimbursed on the Medicare physician fee schedule this year. CMS has just now defined the billing rules for these services. It's typically 60 minutes of time spent by an individual who meets the qualifications of a community health worker. So even though they are typically not clinical staff, they are instead folks that qualify as community health workers, that time that they spend would be reimbursed under G0511. Also new this year is reimbursement for RHCs for providing remote physiologic monitoring and remote therapeutic monitoring. Physiological monitoring has been reimbursed on the fee schedule since 2019. Therapeutic monitoring came online in 2021. And finally, after many, many comments, CMS has determined that those services will now be reimbursed for RHCs as well. Again, these services will be billed under G0511. CMS has also created separate reimbursement under G0512 for the psychiatric collaborative care model. The reimbursement, as you can see, for 2024 is significantly higher. This is a much more involved service. It includes, as part of the care team, a psychiatrist who advises the RHC staff on managing these patients. Given that higher level of involvement, that higher cost structure, CMS has provided that higher reimbursement. Let's talk about some unanswered questions we have under the care management codes as a result of CMS expansion of coverage in 2024. Back in 2019, CMS had published an FAQ regarding care management services furnished in FQHCs and RHCs, where it stated very clearly that you may only bill 1 unit of G0511 in a calendar month. And the example given there was care management services, that you bill G0511 for 20 minutes or more of care management service. It didn't matter if it was 40 minutes or 60 minutes, it would only be 1 unit of G0511. Compared to the fee schedule, when a physician practice provides that service, it has an add-on code for each additional 20 minutes of services. So they bill the initial 99490 for the first 20 minutes, and then they bill additional add-on codes 99439 for those additional minutes of care management services. But we always understood as RHCs, we had one bite at the apple and would only be able to bill G0511 once. With the addition of the remote monitoring codes as part of care management services in RHCs, however, CMS was challenged because now there are now an opportunity for an RHC to provide multiple types of services that are care management services. So CMS in 2024 has now said that an RHC can bill multiple units of GO511 in a calendar month, provided all the requirements are met for that particular type of care management services, and your resource costs are now not counted more than once. So you can't bill the same time, can't count the same time towards two different services. What that left us with is some unanswered questions that we're looking for additional guidance from CMS, and I have no wise wisdom to share here except to point out that they are open questions. Can you bill GO511 for each 20 minutes of chronic care management services? So now, if you do provide 40 minutes of services, does that give you the opportunity to bill 2 lines of GO511 and receive that $72 in reimbursement twice? Even more complicated are billing GO511 for each component of remote monitoring services. Both RPM and RTM are a set of codes as opposed to a single code. There's a code for education and setup on the device, which is 99453, which on the fee schedule reimburses at about $20. There's 99454, which is the monthly monitoring fee, so the expense of pulling data from the device and having that data available for analysis by the practitioner. That's a monthly monitoring fee. Into the fee schedule reimburses at about $50. And then there's 99457, which are treatment management services. So these are, again, performed by clinical staff. This is the interaction with the beneficiary regarding that data, regarding counseling patients on the data, reviewing the data, and the like. Like chronic care management, it's counted in 20-minute increments. Like chronic care management, there's an add-on code for additional 20-minute increments. And so that's the open question, is if I start initiating a program of RPM, do I in fact have an opportunity in some months to bill 4 units of GO511, which certainly the reimbursement for GO511 is significantly greater than what's available on the fee schedule, really creating an interesting opportunity for RHCs to get into the remote monitoring space. People will need some additional guidance from CMS here so that we can manage the risk appropriately. But at this point, what the guidance says is you can bill multiple units of this code. And they specifically gave the example of monthly monitoring fees and treatment management services could both be billed for that time. Also appreciate that GO511 and GO512 are separately payable, even if billed with the same date of service as an RHC visit. They would not roll into the air. Briefly, communication technology-based services. This is G0711, O71, reimburses at about $13. This is 5 minutes of virtual non-face-to-face communication between the practitioner and the patient, or the practitioner reviewing recorded video or images delivered by the patient. Again, service that's reimbursed on the fee schedule. They've created an equivalency for RHCs to bill for the service. It's low dollar, but this could be a way to capture reimbursement that for services you're providing now without any sort of reimbursement. Keep in mind, this is only available for patients that you've seen within the last year. You have to make sure the patient consents to the service being billed to them. And again, it must be in lieu of an in-person visit. So again, that can't originate from a prior visit, can't lead to a new visit. Finally, in RHC services, we get to vaccinations. Very briefly, for both influenza and pneumonia vaccinations, you do not bill for this on the UB. Instead, you are reporting these on the cost report and are being reimbursed through the cost report. And in this case, coinsurance is waived for the beneficiary. Let's talk about then, so those are our RHC services, all are special unique reimbursement that we receive for billing those services. But that does not mean an RHC cannot also be reimbursed for non-RHC services. These are simply test services that are going to be reimbursed on the Medicare physician fee schedule. So what's this going to include? This is going to be the clinical lab tests. Yes, again, you're required to be able to provide these tests in your clinic, and then you're also going to be able to bill for them separately on the fee schedule. Remember, venipuncture is included in the air, so it is not a separate reimbursement on the fee schedule. Again, if you're an independent RHC, you're going to do that on the 1500. If you're a provider-based RHC, you're going to bill, the parent hospital is going to bill it on the UB. Also reimbursed as a non-RHC service are the technical component of diagnostic tests. So if you're doing x-rays or EKGs in the clinic, that's also going to be reimbursed on the fee schedule. Same manner as clinical laboratory tests. And then importantly, any professional services that are furnished in hospital, inpatient, and outpatient settings by RHC practitioners, those again are going to be billed by both the independent and provider-based RHCs to Part B on a 1500. Note, however, that all costs associated with non-RHC services must be removed from the cost report. Finally, let's talk about the impact of the Merit-Based Incentive Payment Program on RHC practitioners, or MIPS. So if you live on the physician fee schedule, you know that under MIPS, you have certain requirements to report quality data. You have to engage in practice improvement activities. You have to submit certain data to demonstrate your use of an electronic health record. And then there's a calculation that CMS does on cost of care. All of that data is used by CMS to determine a practitioner's score under the Merit-Based Incentive Payment Program. And their performance in year one and the score they receive impacts payments then in year 3. So it's the performance year, then the 2 years later is the payment year. And you can have positive adjustments if you do well, or you can have negative adjustments if you don't report, or if you perform poorly. These, again, are payments that adjust physician fee schedule payments. So RHC services are not subject to MIPS adjustments. However, non-RHC services that are furnished by an RHC practitioner are subject to MIPS reporting, and if that clinician furnishing the services exceeds the low volume threshold. And you see there are 3 components of the low volume threshold. You have to meet all 3 to be required to report under MIPS. So in most cases, a lot of RHC practitioners will not cross that threshold with their services furnished in the hospital, inpatient, or outpatient setting. And thus they are not subject to MIPS, but be aware you are doing a high volume of those services. If you have a high number of non-RHC services being billed to the RHC, that you could have MIPS reporting requirements. For a number of RHCs, we hung on. This is our last year to request the extreme and unusual circumstance exceptions for COVID. So many did not have to report this year, but coming now into 2024, very unlikely that CMS is going to extend any type of extreme and uncontrollable circumstances exception. So if you are beyond these limits, you are looking at reporting MIPS. Again, CMS's Quality Payment Program website has a tool that can be utilized that you can look up and determine whether you meet or exceed these standards. But also, if you have services that are reimbursed under CAW Method 2 billing, so it's not the RHC billing for the services, but it's the CAW billing, and receiving that 115% of Medicare physician fee schedule for those services, those CAW Method 2 billings are included in the calculations for low volume threshold. So assuming that the payment's eventually coming back around to you in some form, CMS is capturing that billing under your MPI for purposes of calculating the low volume threshold. But then, interestingly, the MIPS adjustment is going to be made to the payments made to the CAW, that 115% of fee schedule. So we need to make sure we've got MIPS on our radar screen, depending, again, on that number of non-RHC services that we're billing. I have unfortunately made it to the top of the hour. I'm happy to stay on the line, Cassidy, and answer questions that we have. It's just, you never know how long it's going to take to get through this stuff.
Thank you, Marty. That was excellent. We actually do have several questions, and we can just kind of move through those. And some of these go back to the first 20 minutes of the presentation. But what about the first question states, what about RHC visit in a non-Part A NH?
That's considered patient home. So if a patient is in a long-term care facility, that's considered their domicile. And so those are appropriate to bill as RHC services, just as in the patient's home.
Perfect.
And that's the revenue code you would use.
Thank you. The next question states, I've been informed that podiatrists are also approved RHC providers. Is that correct? And then someone responded that they have a podiatrist in their clinic.
I'm sorry, the last part of that?
Another participant responded that they have a podiatrist in their RHC.
It's the definition of physicians, which I believe and I don't have it in front of me, Cassidy, and I'm very quick to say when I don't know for sure, but we can look that one up. I know for FQs, I know it works, but I'm not absolutely sure for purposes of an RHC.
Next question, does the behavioral health provider conducting the telehealth visit have to be physically located in the RHC while seeing the patient, or can they be remote?
No, they do not. At least, and I'm gonna preface that with at least through December 31st of this year. We'll have to see if there's some additional CMS guidance that comes out on these services, but as it stands today, no, they may be located as long as they are an RHC practitioner. So they're being, there's compensation from the RHC for the services they're providing. That works. And yes, we're seeing RHCs that are contracting with third parties. So you'll have a physician practice furnishing behavioral health services. They're contracting with RHCs, providing services to RHC beneficiaries, and they are qualifying through that contractual relationship as an RHC provider, an RHC practitioner.
The next question states, can you provide insight on how to get secondary coverages, specifically Medicaid, to process that deductible remit? We get denials for invalid primary POB.
It's one at a time for those denials by secondary payers. Again, you have guidance from Max out there saying that the copay should be calculated based on the error. That's not what the statute says. It's not what the regs say. It's not what CMS guidance says. But it's simply going to be a case by case, working with that supplemental payer to make sure you're getting appropriate reimbursement.
Excellent. Next question, what about an RHC visit and a virtual specialist like a cardiologist visit at the RHC the same day?
Okay, so this is the cardiologist. This is
Debbie. I like here.
Let's see if I can work one more time. I want to make sure I can figure out who's on first and who's on second on that one. Cassidy, I'm sorry.
Sure. What about an RHC visit and a virtual specialist, cardiologist, for example, visit at the RHC the same day?
If it's a cardiologist who is not an RHC practitioner, so they're going to submit their own claim under the Medicare physician fee schedule for their professional services. What is available to the RHC to bill is the originating site fee. And that code, which I can't think of right now, that's the one that pays about $30. And that is the reimbursement for the originating site fee is in addition to the CG line. So it's not wrapped into the error.
Thank you. Is there more information about the criteria for the add-on code G2211?
It's a mess. How's that? I'll say that very briefly. We did where I can point you to is PYA did a webinar last week on everything we know about G2211 right now. And it's not a lot. It's what was in the proposed and final physician fee schedule rule. It's the CPT code definition is it's an add-on code for complexity of managing a patient through over a patient longitudinal relationship. And that can either be primary care, which is generally what the RHC is providing, or it can be a specialist who's managing a single complex condition over a period of time. So it's intended to be that additional reimbursement for the service. And again, in its commentary and discussion of this, CMS has not addressed whether it can be included in an RHC claim or not. And again, it's not going to impact anything except the copayment amount, because it by definition can't be a CG line because it attaches to the E&M code that's on the CG line. But what we know from CMS, there was a a physician open door forum in mid-January where they went through several questions discussing it. But I would refer you all to the webinar that's on our website on G2211. That's everything I know about it, at least.
Thank you. Does any payer accept traditional Medicare paper revenue code 0527? We are considering closing our home health agency and would like to cover this service in our RHCs.
Interesting. It's going to be case by case. It says everything. Once you get outside traditional Medicare, it's what your state Medicaid rules are and how they would treat that. And then it's what you've negotiated with the MA plan or the commercial payer. An MA plan, that's interesting though. An MA plan is obligated to cover the same services that traditional Medicare covers. The rate can be different, but they can't vary the coverage rules. So the fact that that would be covered under traditional Medicare makes sense that would have a strong case to the MA plan that they should cover those services as well.
The next question states, we have 2 new MDDOs. How many patients do they need to see in a year? How many DO patients? I'm not sure I'm reading this correctly.
Yeah. I think you're getting into the productivity standards, and which we didn't address because productivity is an ongoing battle. And I don't have the productivity numbers in front of me, but that's what this question goes to, is if you can meet the productivity requirements so that and that's how you ensure that it's appropriately reimbursed RHC service. So sorry, I'm going to take a pass on that one.
Not a problem.
Can I phone a friend? Oh, well, I'll ask Google.
Right. Can you elaborate on RHCs not eligible for 340B drug pricing? We order meds through the hospital pharmacy who does get 340B pricing. Is this okay?
I mean, the provider base. I mean, if you're provider based and you're associated with the hospital, if you're a provider based RHC and it's a critical access hospital is the hospital or a disqualifying hospital, then they would have 340B, and since that would allow the extension of the services to the RHC, but the independent RHCs do not qualify. And again, it's all going to be based on the hospital's qualification.
Can care management services be billed by clinical staff under the supervision of the APP or MD?
This care management services are billed as RHC services when they're billed by an RHC and under the GO 511. And those services, just like an RHC service, it can be provided by, that supervision can be provided by a physician or a non-physician practitioner, that general supervision. And it's not going to vary the payment rate under GO 511 as it does under the physician fee schedule. So same service under the physician fee schedule, if I bill it under I always have to bill the service of the physician fee schedule under the MPI of the supervising practitioner. If that's a non-physician practitioner, I take a 15% haircut on the fee schedule rate. In the RHC setting, it doesn't matter. It's not billed under a specific MPI. It's billed under the RHC CCN. And it does not matter if it's a physician or a non-physician practitioner who is supervising the clinical staff. It's going to be paid at the same rate.
And then, will we get the ARX2 when billing for primary care and CG modifier and behavioral health and CG modifier?
Yes, that's if you provide a medical service, so whether it's a procedure or an E&M code, and then you also provide one of the behavioral health codes, and if both have CG on them, then you'll be paid 2 ARs for that.
And then finally,
80% of 2 ARs. Sorry, always forget.
And it looks like this might be the final question. What justifies the additional add-on code?
And again, that's the G2211. It's that longitudinal relationship with the patient. And what defines the longitudinal relationship is really what we're now developing up now that the code is live on the fee schedule.
Okay, and I think, Marty, let me do one last run through, but I think that's it. Oh, I'm sorry, last one. Can we have home health under RHC? If not, other home health providers, if there are no other home health providers in our region.
I think the earlier question actually got to the model, right? I mean, there's a visiting nurse, the limited circumstances under which visiting nurses services can be billed as RHC services. So there's that avenue to follow, but they're very specific requirements. And the other would be having those services furnished by an RHC practitioner in the patient's home. So you would not, they're very I guess what I'm saying in short is there are limited circumstances in which you can bill for nursing services as RHC services, and it's that meeting those visiting nurses requirements. And again, I didn't go into the detail there on that issue. But again, my email is at the front of this presentation that the center is going to email out to you. Happy to address any follow-up questions if you have them.
Well, we got a couple of responses in the chat saying great information, great presentation, and we always appreciate you, Marty. We will send out a follow-up email with the link to the recording of this presentation as well as a copy of the slides. And then, any questions that come in between now and then, we will make sure Marty gets those and we get a response back to you. I did just launch a quick 3-question anonymous poll. If you wouldn't mind giving us your feedback, we would appreciate it. And we thank you again for your time and hope to see you next month on our next webinar. Thanks, everyone.
Thanks, everyone.
Bye-bye.
Cool.